Hi everybody, welcome back to AP Psychology, part 2 of the treatment of psychological disorder. Be sure to fill out your binder notes for this part of the video on pages 14 and 15 of your Unit 8 binder notes. I'll see you on the other side. Okay, so next up for our psychological therapy notes, we've done psychoanalysis right through behavioral on the chart, and now we're going to move on to cognitive therapy. And I just want to remind you about cognitive. One of the buzzwords for cognitive is thinking, right? Cognitive means thinking. Thinking means cognitive. So when you do cognitive, you think. So thinking, right? We see the root of psychological problems coming from irrational thinking or the wrong thought process. So under the aims column for cognitive, you want to put essentially this paragraph here that will teach people more adaptive ways of thinking and acting by ridding the person of their false thoughts, by helping them to understand, as it says on the slide here, that thoughts intervene between events and our reactions to them, okay? So as it shows you, it's kind of in the diagram here. If someone loses their job, for example, they could very much have the internal belief that they're worthless or life is hopeless and they're always losing their jobs and they have no worth and they're no good, and it leads to a reaction of a depression. So a cognitive therapist would try to rewire, right, and help them to see that a loss of a job, or almost rationalizing it, or to think about it differently, like, well, if my boss was not such a jerk, or I deserve a better job, and then that leads to less depression or thinking, right? When you take the blame off of yourself and say, like, maybe your boss wasn't seeing how great you are, and maybe we can work on a plan to show you how to highlight those things on your next jobs. Cognitive therapy for depression, we've got rational emotive therapy and cognitive behavioral therapy. But first I want to talk about how cognitive therapy is very applicable to depression. You might want to do this, and some blank space somewhere loosely in the margins is that Aaron Beck is huge here. In fact, you'll want to write his name nice and big, and Albert Ellis, okay? They are the two huge names that tie into cognitive therapy. But Aaron Beck is a guy who did a lot of research with cognitive therapy and with cognitive therapy and depression, suggesting that depressed patients believe that they could never be happy. And Beck suggested that that's just their irrational thinking at work on their psyche, and thus they begin to associate minor failures. For instance, failing a math test in school, or forgetting to buy your child an appropriate school supply. And then the patient begins to believe that these little minor events are because nobody cares about them, right? And then they get depressed. So even the smallest thing can trigger it, simply because of their way of thinking, their irrational thinking process. Because everyone messes up, right? Everybody makes mistakes, and that's how we learn. And to think of yourself as inept just because of making mistakes is irrational thinking, according to Aaron Beck. He believes that the patient's thinking, their cognition is faulty. And so you've got to get the patient to change that thought process. And in some studies, they train depressed patients to take recordings every day of the positive events and relate how they contributed to those positivities, how they contributed to those events. And so positive things happening in their own lives, they begin to rewire their own brain. And then compared to other depressed patients who didn't do this exercise, right, there was a much lower depression rate in the depression scores for the ones who had the activity. Under methods, one being cognitive behavioral therapy, also known as CBT, and it very much ties the two perspectives together. But we're going to talk about this one first. So cognitive therapies combined the reversal of self-defeating thinking, that is the cognitive part, but with the efforts to modify the bad behavior as well. hence the behavioral part, okay? So this therapy aims to alter the way people act, but also the way that you think. The maladaptive cognition or thinking, and adopt a more effective thinking thing. That's the basic way of cognitive therapy. And then the cognitive behavioral adds in some kind of self-reinforcement. As it says there for you on the chart, you should also write the acronym REBT next to cognitive behavior therapy. This is rational emotive behavior therapy. And this is huge. The role of the therapist believes that the most problems come from irrational thought. Therapy involves showing the patient their distorted thinking so they can eliminate it. But it helps to individuals to see their false ways of thinking. But rational emotive therapy does so in a very direct and confrontational way. I would highlight that, okay? That's rational emotive therapy. It's very confrontational. And really, cognitive therapy in general is the most controversial because it's kind of the aim of the therapist, which is to essentially get in someone's face saying something like, this is what you should be thinking, so let's fix it, right? Let's fix it. In actuality, it is in the confrontation of the therapy that the therapists are being therapeutic for their patients. Okay, so let's really quickly sum it up with family and group therapies. So you treat the family or the group therapy group as a whole to overcome the problems, which normally consist of 6 to 9 people with 90-minute sessions. It contains a group of individuals all with the same types of problems. So you might discuss as a group what each of the people are feeling and what each of them are going through, and then everybody sort of helps by listening to each other. Group therapy was shown on the VH1 OCD project that we did. That was an example of group therapy, and they very much benefited from knowing that the others have similar types of problems. Even though each person's problem was unique, the underlying symptoms were similar. Okay, and then with family therapy, which is the last one for this side of notes, family therapy is where you treat the family as a system, okay, in order to resolve the problem by setting up some kind of scaffold in place to heal the relationships and improve the communications systematically, or one little baby step at a time. Each person has their own unique problem, or all the people in the family have their own dynamics, and they would get at the bottom of each one of those dynamics and kind of work on it as a whole, and then within each of the pairs. Okay, so you should be turning your page now, and now we're going to move away from psychological therapies and into the biological or biomedical therapies. Okay, so we're on the back of the chart now that you just filled out. And just to clarify, we've talked about this already in part 1, the biological therapy. Okay, so the more physical treatment in which we are mostly talking about is pharmaceutical drugs. Okay, we've got to first understand the type of disorder that we're dealing with and what exactly is going wrong. So for instance, with depression is a lack of a neurotransmitter that we have learned about called serotonin. So what the drug is prescribed for people with moderate to severe depressive symptoms, what they are going to do, well, hopefully they will somehow increase those levels of serotonin. But then we also have to know on the other side of that some side effects, right? So here's a chart for each of the drugs and each of the different side effects. First up are our antipsychotic drugs. So underneath these drugs, in the first column, put in parentheses schizophrenia. That's an example of an antipsychotic need for a drug. So our antipsychotic drugs treat schizophrenia, and these include chlorpromazine, Thorazine, clozapine, Clozaril, Seroquel, Risperidol, Zyprexa. All of these will block the serotonin and the dopamine, which with schizophrenics, they have too much of. Okay, so most of them block the dopamine receptors as an antagonist. That's a big, huge one back from Unit 3. Again, remind yourself what's wrong with the schizophrenic patient, right? They have too much dopamine. Okay, so these drugs help by flooding those receptors, and the doctors are, more importantly, the patients will usually see really good results in about 4 to 6 weeks. However, there are many side effects because we are blocking that dopamine, which is also our body's own feel-good drugs. Okay, so blocking dopamine in the brain also brings with it these feelings of sluggishness, facial tics, and other involuntary movements. It's almost as if it's like an induced Parkinson's or Tourette syndrome, and they call this system of facial movements tardive dyskinesia. And for some reason, the College Board really likes this term. It really likes this side effect, meaning it comes up on the AP exam a lot, and it has come up in both multiple choice sections and FRQs. So just make sure you know that tardive dyskinesia. There's also the lowering of white blood cell counts. Many people also report significant weight gain. Next up, we have a class of drugs that treat bipolar disorder. These are going to be anti-manic and antidepressives. Okay, so lithium is probably the most common, and it can also include some other anticonvulsant medication, like I think it's Depakote. And usually what this one does is it reduces the manic activity, so it kind of slows the brain down, right? Like it brings that mania and that pressured speech down to where it needs to be. Usually lithium works within a week. However, it is a very powerful drug. It's so powerful, so you have to make sure that you work with a good doctor and that they prescribe the right dosage, because it can be toxic. And they need to be very careful and cautious not to take too much of this drug because of the toxicity. Next up are antidepressant drugs. There are a couple of different types. We have SSRIs, Prozac, Zoloft, Celexa, and Lexapro, and SRIs, which are Effexor, Pristiq, Cymbalta. So the SSRI are serotonin reuptake inhibitors, okay? They are inhibiting the reuptake of the serotonin. So remember, depression is caused by a lack of serotonin in our brain. So patients with depression to take more serotonin. And what the SSRIs do is they block the reuptake. It doesn't get absorbed and then into the bloodstream and go away. Reuptake it and use it again so that they start to, their feelings of depression and cloudiness will start to lift. NSRIs inhibit the reuptake of the serotonin and the norepinephrine. Both work similarly, and with both medications, patients will usually start to see their depression cloud fade within about 2 to 4 weeks. There are some side effects with these drugs as well. Until they are reabsorbed by the receiving neuron, there is often dryness of mouth, constipation, headaches, and weight gain. Okay, next we have a class of drugs for treating anxiety. These are our anti-anxiety drugs for general anxiety disorder and OCD, called benzodiazepam. There's Librium, Valium, Ativan, Xanax, and what these drugs do is they reduce the intensity of the response to the stimuli that is making the patient feel anxious. Okay, that signal of punishment and frustration. So these are kind of slow down the sympathetic nervous system so that when we notice the anxiety provoking stimuli, our body's not going to get that anxiety provoking response anymore. It's going to cover it up and absorb it and kind of lower the inhibitions. Some of the side effects of these are drowsiness, reduced ability to concentrate, right? Because we're slowing down the brain, right? We're quieting down that sympathetic nervous system. So our ability to think clearly and to concentrate isn't there anymore. And you might feel lethargic, and you might get sleepy, and you might also get physically dependent, right? They're very addictive. Okay, some other therapies that are not drugs are ECT, or electroconvulsive therapy. There's really no real forms of this, but this is used for what we call shock therapy. and it's used to treat severe depression. And basically what it does is these electrodes here that are on the skull, and it sends electricity to the brain, and basically what it does is it's able to reset the hypothalamus, which then resets the hormone levels, and there has been tremendous growth in this method when precisely used. We are sure that it helps with symptoms of depression, but some people, it's not a magic bullet for all cases of severe depression. There are, however, some very small effects on memory, and that's not really good, but because of, I guess in the name of it, the electroconvulsion therapy, people still worry about the safety of ECT, even though there are very, very small side effects. And now, with the electricity that goes through the electrodes are so finely tuned, it's so much different from like the old movies that we've watched where, you know, the whole brain is like getting zapped. It's not like that anymore. Okay, and finally we have psychosurgery. Psychosurgery is a lobotomy. Okay, lobotomies are still done today, and basically what they do is sever the nerves between the frontal lobe and the centers of the inner brain. It's going to, you know, keep those pathways from happening, and so the frontal lobe is where someone might have a lot of their impulse control, and their judgment is all up there. And so there is a severe lack of judgment. And if someone lacks that ability and we sever those structures, it could be very scary. But if they get it right and they can get rid of the depression, people have had a tremendous, monumental change in the way that they live their life depression-free. So you have to kind of weigh the side effects and the main thing that it's fixing. Alrighty, and that just about wraps up clinical psychology. Have a great night, and I'll see you tomorrow. Bye now.